those of you who are new to the Big Innovation Conversation, it's a monthly WebEx that we do of presentations and discussions that are based on our innovation themes and categories that we have here. So today we're going to focus on the Digitising the System theme, and I kind of wanted to frame this around one of the big programmes of work that's supporting digitising the system at this point in time, which is the local healthcare record Exemplar programme, or you might have heard it as a LHCRE, or maybe even a LHCR. There are many different terms for it, but essentially that's what it's based on. More locally, you might know it as Share to Care. And the systems involved you may have heard of things like LPRES or e-exchange. So all of those terms are linked very much into what the LHCR programme is trying to do. So to give an overview of this, we're very lucky to have John Farenden here from the National Programme, who's the Senior Programme Lead from NHSX, and he's going to give us a bit of an overview on the LHCR programme and where it's heading and where Share to Care fits within that. Following on from that, I thought we could then have a bit of a look at personal health records, or PHRs you might have heard them called, which is a programme that will be enabled by the implementation of the LHCRs and allow patients to start getting access to their full record, not just the primary care record. So to that end, we've invited Zan Virtnik and Matej from Parsec, who are developing a PHR for Lancashire and South Cumbria called Wellpress. And also we've got Kumar Jacob on, who's going to do a presentation as well, who's from Mindwave and has been working on a PHR with MERSEY for Cheshire and Mersey. So they're going to give us an overview of the work they've been doing to date on PHRs in the areas and give you a chance to see what those PHRs actually look like. So before we begin, just a quick bit of housekeeping for you. So everybody's on mute as you came in. And also, if you've got any questions, if you can put them either in the chat or the Q&A boxes down the side, and we will get to them. So we'll start with John, and we'll let him do his presentation, and then we will do Q&As after, because we appreciate John is currently in the middle of a conference and has took time out to do this for us, and it might be that he needs to leave. So we'll do that as a separate piece with questions and answers, and then we'll do both PHR presentations, and we'll follow them with questions and answers for both suppliers around PHRs on that. So without further ado, I shall hand over to John to give you an overview of the LHCR programme.
Thank you, Jenny. I'm just trying to make sure I can see what I'm doing. Fit to window. That's interesting. Why is that not working? Share. Arrange. I am presenter, am I now?
Yes, you are presenter, John.
Oh, I know why it is. I'm pressing the wrong button. There we are. Technology, don't you just love it?
I know, technology. Why do we work with it?
Oh, thank you. Right, I'll get straight on. So I'll go on straight away and just do an introduction. So as Jenny said, I'm Senior Programme Leader for the Local Health and Care Record Programme.
John, sorry, can I interrupt? We can't see your presentation, sorry.
Oh, gosh. Right. What's gone wrong here? Share.
Share my screen?
Yeah.
Ah, we got it.
Good. Right.
Apologies for the interruption.
No, that's just as well. Otherwise, I could have gone on for ages. Let's get it big screen. So yes, as Jenny said, I work for NHSX, which is the new virtual body at the moment, bringing different pieces of NHS England and the Department of Health and Social Care digital teams, NHS Improvement, and some colleagues from NHS Digital together to give a real good focus on the strategy and policy agenda, as the Secretary of State had felt it was a bit fragmented. So we've created that new virtual body, and we formally launch in July. So that's who I am. I was going to start by just going back to the long-term plan and reminding ourselves of 5 of the big key changes that are flagged up in the plan. The 4th and 5th of which are particularly pertinent. Whoops, I've gone forward one for my talk today. One is about the emphasis on digitally enabling things. It talks about primary and outpatient care, but it's generally, we are going to use digital technologies to a much greater degree to deliver the objectives of the long-term plan. And also the role of the integrated care systems as a way of bringing together all the different organisations involved in the planning and delivery of care in a much more integrated way than we've perhaps had in the last few years. For those of us who've been in the system for quite some time, it feels like we're going back to a generation or era before. But anyway, so we have some very specific commitments in the long-term plan around local health and care records. Those are 5 of them. Pertinent to today, it does talk about the importance of patients having control over their records. Those are the words that are actually put in the plan. So when I say it's medical records, I would say actually it's health and care records. And that we will make it much more of a way of communicating, not just between professionals, but also between patients and citizens and carers and professionals. We have a particular task to cover the whole country, and I'll talk a little bit about that later on. But we are aligning what we do around those commitments that were made in the long-term plan and working out how best to do them. Although, to be fair, the local health and care record programme existed before the long-term plan, so it's really just a question of aligning. What is it? Well, put simply, it's a pre-life to post-death record of an individual's interactions with the health and care system. When you say it like that, it seems very simple, and I think it's fair to say that many people in the population assume that as a national health service we do that already, and get surprised and often frustrated when they find that we are sort of separate organisations and there's exchanges of information between them. They kind of expect that our professionals would have access to all of their records when they need them. And why do we need them? Well, we need them to help patients and their carers. We need them for the professionals. We also need to be able to aggregate anonymous data to help with our planning and management of the whole health and care system. And we can also use it for research purposes. So it's a multiplicity of end users. And so we talk about our user needs. We think about the particular examples of the issues that have arisen and how through our national programme we can help localities to address some of those problems. The sad case of Tamara Mills, lots of interactions with the health service, but they didn't link her records together, and that may have been a contributing factor to her death. But professionals, both healthcare and social care professionals and managers, would also see benefit. A good example is thinking about what we technically call a theograph. What's gone on an individual's journey of care. This is an example of a dementia use case that's come from our Exemplar in Greater Manchester. And it just illustrates at various points on the journey, there have been interactions between the person with dementia and the carer and their GP on the left-hand side, and then over time with a different range of different services. The thing that is consistent on that is that the individual and their carer who interact on every particular point, as you'd expect. This has a very sort of personal resonance, as my father has dementia, and it looks identical to the journey that he and I have been on. So what we're trying to do is say any of those professionals involved in any of those organisations or services ought to be in a position where, with agreement, they can look at those historical records of the interactions and not treat each patient encounter as an almost unique event. These things aren't new. When we started our programme, we did a bit of a survey and identified that there were already over 60 instances of shared record solutions dotted around all over the country. They'd sprung up organically by local organisations working together, but they varied greatly in terms of the different numbers of participants, some of the functions that they were providing, and in particular, their lack of consistency in the use of standards. So while they might be able to communicate within one small locality, they couldn't share information readily with others in other parts of the country. So part of our job was to build on the learning of those shared instances and try and put some structure and form into the standards that are needed to assure interconnectivity. So we're starting with quite a rich legacy of experience, and we're trying to make sure that we learn from the best. Our philosophy as a programme is that it is very much locally driven. We see this as empowering localities to take forward the agenda, because as we've just seen, they recognise it's a need, and we want that conversation to take place at a local level. And our job as part of the national team is to say, well, what are the things that we really only want to do once, and we'll take the responsibility for fixing those. So a lot of stuff is going to be about the standards, whether they're technical standards to allow different computer systems to work together, clinical communication standards so that a hospital consultant understands what the social worker's written and vice versa, standards around information governance, which are absolutely fundamental, and standards around cybersecurity. So our job nationally is to make sure that there's a single set of standards that people work to. Actually, the real hard work goes on in our localities, and I'll talk about where they are later. So we've tried to look back at some of the things that have happened in the past and take learning from that to avoid us making the same mistakes again. And the one at the top, and one we keep saying, is it's about maintaining trust, the trust and confidence of the population in how we use and share health data. And there's some evidence of why that's so important, and then we talk about what we do to address it. And I'm not going to go through each of those rows in turn, but what I want to just get over is the point that we do want to see ourselves not saying, well, it's a new idea, because it isn't. Let's see what learning we can get from our past experience, and where that hasn't gone well, see if we can make sure that we address it. So those are some of the key principles that we're adopting to try and make sure that we don't fall into the same mistakes that we have perhaps done in the past. So some of the things we've learned from the programme so far, I'll just touch on these very briefly, one each. Planning. It's been fascinating to see how different localities have coalesced together, and they're doing that at a particular scale. We heard about Share to Care, which is the one that's covering the Northwest, and Greater Manchester is another one. But we've also got them in other places over the country. I've got a map I'll show you later. But what we've seen is that people from different organisations are coming together because actually they see this as a shared common purpose. They all want to work on this problem together, and it's been quite remarkable how quickly some of them have stood up the collaboration. It's a bit harder reaching consensus because once you've got everybody in the room all enthused, trying to work out which particular direction you want to take can be quite challenging. But from a national perspective, we've let people reach that consensus themselves, and I'll talk about some of those journeys later. Engaging, we've got some really good examples of early projects engaging with the public. There's on the screen, Yorkshire and Humber did a big public engagement exercise, understanding what it was that the public were concerned about, why they were frustrated, and what learning we could get from that. They did all sorts of things like pop-up interviews on buses. I always thought getting on a bus and finding somebody sits down next to you and starts asking you about your views on health data might be a bit disconcerting, but that's one of the things they did. And also professionals who are able to say, well, actually, now I can share this information effectively. I can both save time and I can give much safer care to the patients in front of me. So engaging with those communities is really important. We've set up some arrangements that enable localities that want to buy products and services to do so more rapidly and with more greater confidence. In particular, a thing called the Health Systems Support Framework, which has a selection of suppliers of products and services on. And the important thing there is that we have a set of standards, and the suppliers that we put onto the framework have agreed to work and align their products and services with those standards. So that's a way that we can try and make sure that different pieces of the jigsaw, the systems jigsaw, can work together. So that's one of the things that we put in place, and different localities are using that to build their solutions. We've delivered some things, that awful acronym at the top, which is actually really important, the Information Governance Framework for Integrated Health and Care. This came out as an early thing that we were asked to do nationally, because it was quite clear that different people had interpreted national guidance on information governance in different ways, and it was causing a bit of a blockage to local progress. So we undertook to really revisit the gold standard good practice guidelines for dealing with information governance, where we are sharing information within and between health and care organisations. And that's both primarily initially for direct individual care, but we also wanted to tackle the challenges for other uses of that shared data, for example, for population health analysis and management and for research. So we're building this framework that covers a variety of journeys, as we call them. Journey one is that first most important one, the professional and the patient working together, to make sure that people can share data on a legal, lawful basis, and they've adopted all the best practice in terms of how they communicate with patients and the public about how they're using their data. We also have work on national architecture. I'll show you two complicated slides on that. Cybersecurity standards and the NHS app, which is starting to get penetration across the country in its initial release. And that will be pertinent to the conversations you'll have after mine. So the architecture, I won't go into this in detail, but just to tell you, we have a kind of technical map of the different things that we believe a local health and care record solution will need to tackle, and there are descriptions of each of those. And our localities are basically saying, right, if that's what we've got to build, what have we already got, and how can we reuse that, and where do we need other components? We also have what we call our fixed requirements. So this is a bit like the highway code. We're telling people where we'd like them to get to, but we're not prescribing the roads that they take. However, there's a set of rules that they have to adopt to drive safely. And you'll see in there, the fourth one down, you must operate to the Common Information Governance Framework. That's one of the must-do mandatory rules. So we're setting out that rule book. We're giving them a map, and then we're basically giving them some money, and we have a funding agreement. So they tell us the route they're going to take, and we agree how much funding we're able to give them at different stages on their route. So it's a map, a set of rules, and some resources. Ultimately, we're going to need these regional solutions to interwork together. So if I happen to live in Southport, I may be a member of the Share to Care record, but I may then travel to Manchester for some specialist tertiary care in the proton beam therapy centre. We need to make sure that the information can flow effectively between those different localities. So that's another task that we as a national team need to help coordinate. This is a transition path, and again, this is a slightly technical, but we start off with where we are at the moment, where we've tended to have individual information systems that often have the data locked inside them, and it's really hard to get the data out and share it. So we struggle. We have lots of point-to-point connections that we go to. And what we want to try and do is disconnect the data that we hold from the different applications. So we call that a platform layer, a data layer. So that regardless of where you are, that data is independent of the functionality in the applications that people are using. And ultimately, actually you can just call up the data from as and when you need it, distance away, especially such a legacy that we have. It's the kind of solution in some other industries, it's something we would aspire to, but we're realistic enough to know that if we can just get from the current state to that interim state, would have made a big difference. One of the important things that's happened is to produce a core common information standard, which is basically saying, what is the data that would be useful to share? So there's been a very extensive project, piece of work undertaken, talking to professionals, and essentially saying to health and care professionals, if you had this piece of information, would it change or could it change the clinical decision you took? And if it does, then we ought to include it as something that does have value to be shared. But we've also asked patients what they would like to share with their professionals so that they don't have to repeat that time and time again. And it's been focused initially on that direct care, individual care journey, but we'll continue building that over time. So we've just managed to produce a stable version of that as of the back end of last month. And now our localities are going to start testing out how that might be put into practice in their own locales. And that has a big map on it that shows the different components of the information and breaks them down in a systematic way. So in that top left-hand corner, most importantly, it's the patient and what they want to share with the professionals that see them. It's a big, interesting question of scale. When we started this, we weren't prescriptive about what we expected one of the localities to look like, although there was some guidance, which I'll touch on in a minute. But we said it's most important that it's about patient flows. Where are the sort of key flows of patients around? It's about having a sense of geographical and place-based identity. It's about the ability of multiple different organisations to recognise the value of working together. And it's about doing things on a scale that's sustainable. So not lots and lots and lots of little solutions, but something that's at a pretty wide footprint. And we learned from Professor Ian Buchan, who's now Professor at Liverpool University, who did a piece of work that talked about his concept of the diameter of trust, where he concluded that sometimes when we try doing things at a scale in the past, we have public trust and engagement. It just doesn't sort of happen. And so we basically said, we need to have things that are at a different level, which is large enough for economy of scale, but nevertheless small enough for a conversation with local public about data sharing. So it is about recognising the regional identities and where people feel more comfortable about having their data shared and avoiding a kind of big national database discussion. So when we went out to ask people if they were interested, we didn't prescribe the population size, but we said, we think it might be between 2 and 5 million, something of that order. And what we found was that we had responses where a large proportion of those came within that boundary between 2 and 5 million. There were some exceptions. The one on the right-hand side of that is One London, which heads up towards 8 million. You kind of understand that because London is a place and therefore it has an identity. It's probably more of an identity as a Londoner than necessarily a South Londoner, an East Londoner or a West Londoner. But you'll see in the middle that a large number of those fit within the 2 to 5 million, and there's a couple of small ones, a small one that may change. Those are still we're just negotiating and seeing what works. So we haven't been prescriptive. We've basically said it's back to patients, it's a sense of identity, and it's a sense of collaboration between organisations. Our initial wave, our Exemplar community, consists of 5 localities. We've given them each 7.5 million capital, and together they cover almost 42% of the population. So this is, quite large-scale stuff right from day one. And you'll see on the right-hand side where those localities are. And they got started midway through last year, and you'll see some of the numbers there, the number of different organisations who are collaborating across those footprints. Some are perhaps simpler than others. You might think Greater Manchester, devolution area, it's basically one integrated care system, and that contrasts with Thames Valley and Surrey, which consists of several integrated care systems, one sustainability and transformation partnership, and it also has a devolved administration in Surrey Heartlands. So that's quite a complex mix of organisations, but they've demonstrated that they can collaborate just as well as anyone else. So we basically said, here's our end point. It's all about that shared longitudinal record and some particular things we want people to demonstrate that it's actually being used and it's useful. But we wanted people to decide where are their priority areas to start with. So some of those localities have chosen to work on urgent and emergency care, on dementia, on cancer, frailty, and so forth. And what we've said is you each have a different landscape from where you're starting. So we are not going to prescribe the route you take, but we do want you to get to that end point. So over time, I talked about our first wave, which were publicly announced. This is a slightly old slide, so they were announced some time ago. And then we had our second wave. Some extra initial funding came available, and we were encouraged to get a second wave mobilised, get up and started, while we were securing the funds for their continued development. So we have a series of 3 Wave 2 communities, of which Share to Care is one of those, and they're getting started to different degrees. And then we also have to think about how we fill in the rest of the gaps in the country to deliver on the long-term plan commitment. But what we're doing is encouraging these localities to try things out, take slightly different routes, learn about what works, where are the dead ends, where they found some fast roads, and share those between them. Oops, those are the numbers, yes. So what we've said is that for the first wave of those exemplars, here's your target endpoint. By the end of March 2020, We want you to demonstrate that you've got a consolidated longitudinal care record, and you can show that you are flowing some information across there. We want you to demonstrate that you can create joint care plans, because those are really important ways of demonstrating the integration across health and care. You can run some algorithms to show that we're actually improving clinical decision support. We can access that data, or patients and carers can access that data through the NHS app and link to PHRs. So that's another nice link onto the next talk, and a couple of other things. But we recognise that over time, there will be new organisations involved, so care homes, hospices, community pharmacists. We'll have new sorts of demographic data, social care determinant data, data from patients' wearables and so on forth. So, this is like phase one, and we will plan that in due course we'll extend and expand. But let's do this in chunks rather than try and a massive job all in one go. So I think that's really where I wanted to get to, and give you some time to grill me with some questions.
Thank you very much for that, John. If people have got some questions and they want to get them typed up now in the question answers or the chat box, either one. But in the meantime, John, I had a quick question for you. I'm just wondering if you can give us an example of kind of the early benefits that the programme has already achieved potentially, so we can hear what's kind of happened somewhere that's really benefited the system.
Yeah. Okay. No, there's a good example of that in London, where in the East London part, so they're starting in different geographies as well, but in East London, they've linked together a number of their provider systems, and each of those provider systems has the opportunity to flag when they see a patient that they've been considered as potentially frail. So they've got a frailty indicator, but that may live at the moment in a provider system. By integrating them together and providing access through their NHS 111 call centre service, a call handler, once they've identified who the patient is that's calling, can quickly look across all of those different systems to see if any of the providers in the past have identified that individual as being potentially frail. If they do, then they have a different pathway. They get clinicians involved much quicker to engage with the patient to make sure that they have an appropriate, safe course of action. And in the first 3 months that they got this up and running, they identified 5,000 patients for whom they then had a different care pathway than they would have done before. So that was one interesting example where it had made a difference and delivered a better experience and a better outcome for that population of people.
That's fantastic. And is there somewhere that these kind of things being worked, being case studies and published, so that people can go and have a look and see how the LHCR is delivering? Yeah. So this is a fundamental philosophical point of view of our programme. We at the centre don't generate the learning, it's generated at the edges. So we have a program, one of our work streams called Learning from Local, which is a combination of, as you'd expect, a website of resources, of case studies and so forth, videos, all sorts of things that are developed locally. But also we want to very actively go out and support local engagement and conversations. So, if a group comes to us and says, can you come and give us a talk or just share some knowledge, we want to go out and do that. So that's really where the learning happens. It's not with people sort of calling through websites, it's people sitting in, talking and working out plans together. So Learning from Local is our work stream that deals with that. We can share the details of that. It's very open. And in fact, as part of our transition to NHSX, we're going to make it even more open and much more publicly accessible. Yeah, if you could send us the link for that, John, we can then send it out to the attendees and they can have a look at their leisure at what's been going on.
Yep.
Well, that's brilliant. I can't see any other questions that have come through on the questions and answers. So I think we'll, at this point, John, thank you very much for that talk. That was really interesting, and thank you for your time. We'll move on to the PHR side of the conversation, and we're going to start off with Zan and Matea from Parsec showing us Wellpress and the work they're doing with Lancashire and South Cumbria. So if I can hand over to Zan and Matea, please.
Okay, thank you, Jenny. Good afternoon, everyone. I would just like to double check if you can see my screen.
We can see you.
Okay, that's great. Good afternoon, everyone. Again, my name is Virtnik. I'm implementation specialist at Parsec.
And I am Matej Červek, a medical doctor and part of Parsec's expert medical team.
So today we will present you the benefits of Wellpress project to Lancashire and South Cumbria region. The purpose of the project is to provide citizen and health professionals of healthier Lancashire and South Cumbria region with access to remote surveillance platform for different cancer-supported self-managed follow-ups. So the implementation consists of combination of two key elements of Parsec's WORCESTER healthcare solution set. On one side, as you can see on your left-hand side, there is a patient portal for facilitating patient engagement and allowing them to access their electronic health records. On the other side, we have managed care system, which enables personalized and remote coordinated healthcare for clinical teams. The first phase will digitize the 5-year supported self-managed follow-up program for breast cancer, and in the future phases, we will add 2 additional cancer recovery programs, so colorectal and prostate supported self-management follow-up. The solution itself is designed to support patients with stable disease to self-manage their follow-up care. So following treatment of breast cancer, for example, the clinical team assess the patient's eligibility to enter a supported self-managed follow-up pathway by following risk stratification protocols. But if we have a look on the overall benefits of patient portal, is definitely better guidance and patient support, which can minimize unnecessary examinations and unnecessary doctor's office visits and avoid losing patients to follow up. Then we have better patient experience and satisfaction, providing them access that they can access their documents and other healthcare related information, and better control of current health condition. It also enables continuity of care by providing information about patient conditions between defined healthcare episodes. It also increased the therapy compliance and otherwise optimized healthcare service by in-time reaction to patient condition changes. So now let's have a look on a patient-facing solution, which is a patient portal. And patient's responsibilities are to attend annual planned mammography screenings. So this task consists of digital X-ray imaging of breasts. Images are then reviewed by a radiologist who prepares a report. After that, they have to fill out a questionnaire to highlight any red flag symptoms or patient concerns, which is subsequently reviewed by a healthcare professional. A decision is made by the healthcare professional on the outcome of the mammogram and questionnaire results. So if everything is okay or further examination is needed. Now let's have a look on functional perspective point as a patient. So patient can access all different medical information from educational materials. They can also receive different reminders. Patient portal for Wellpress will also be integrated with new citizen identity service, so NHS Login once become publicly available. The next one are my tasks. So my tasks, all tasks are created to help, for example, now for breast cancer recovery program. So all tasks that are created in managed care are created by cancer care coordinator. So in different application, they can see all of their tasks, such as that they have to fill out the questionnaire, they have to attend annual mammography appointment or any other regular appointments, and they can also track their overall progress. Another one is questionnaire. So digital questionnaire, which engage patients to contribute information where and suits them best. Also reduce unnecessary administration overhead and effective information management. Cancer care coordinator will be based on clinical guidelines thresholds, receive a notification to detect and react to potential issues much sooner. On the other side, patients will also be able to access all the documents residing in Wellpress backbone regionally and all manually uploaded documents to managed care, so the healthcare professionals facing solution. In future phases, there is also plans to include also some other structured data such as medications, allergies, conditions, and immunizations. For better conversation between healthcare professionals and patients, there will also be available online messaging, so patients are not left alone after the procedure, and they can easily share information to get in contact with healthcare professional. The last one, but not least, is Health Journal, which involves patients in the process of care and gives them ability to track self-observation. They can also add different patient-generated measurements Manually, they will be able to add such as body temperature, blood pressure, oxygen saturation, and so on. Health Journal will also help them, and it will guide them to be compliant to the digital care plan. And now let's have a look on managed care, which is, as I mentioned before, healthcare-facing solution, and which will be presented to you from a clinical perspective by my colleague Matej.
Okay, hello again. So the solution used on the healthcare professional side is Vitally Managed Care, which is used for implementing, managing, and carrying out of the patient's care plan. The care plan itself is based on a program-specific template, which includes all the appointments and other tasks included in the program. For example, in the case of breast cancer follow-up program, the template is done according to NHS guidelines, but has enough flexibility built in to cover the differences in workflows of individual institutions included in the program. It includes the aforementioned yearly mammographies, questionnaires, and clinical reviews, as well as a number of one-time appointments, such as educational appointments. This results in a well-organized set of data that replaces Excel spreadsheets and similar solutions that were used for managing the follow-up programs until now. The data is accessible all from one place. That means all the schedules of appointments and other tasks, as well as the documents and the patient information. It is also automatically organized and updated in real time with inputs from both the patients and the healthcare professional side. Here we can see, for example, a patient list, and the cancer care coordinator can sort it so all the patients that have a clinical review scheduled for the following week are shown on top, so the cancer care coordinator can organize his or her work for that week. This, along with allowing remote interventions, enables more optimized workflows, less workload, and consequently lower healthcare costs, as well as improved health outcomes. Right now, the implementation of Wellpress and Vitally into the breast cancer follow-up program is already being done. And in July, we start work on implementing it into other follow-up programs being carried out on the same institutions, namely the prostate cancer follow-up and colon cancer follow-up. These implementations will be similar in purpose and basic functionality, but will differ in appointments and tasks that are specific to the individual follow-up programs. They will again be done according to NHS guidelines and allow enough flexibility to cover specific workflows. There are also options for further development beyond that. While all of these follow-up programs are just for monitoring patients when active treatment is finished, and maybe getting information if additional interventions are required, they are thus relatively lightweight, with just a few appointments and tasks every year. But the same solution being implemented here is designed in such a way that in future it could easily be applied to active outpatient treatment of various diseases, which includes more tasks and require greater patient engagement. Actually, the more tasks the patient must regularly do, such as measurement, questionnaire fulfillment, therapy applications, etc., the more benefits can be expected by using these telemedicine functionalities. This is shown by the mounting evidence of these benefits in studies that all use functionalities that are already included in this solution. Just for an overview, if we stay within the field of oncology, but look at active treatment of advanced cancer, the research of telemedicine interventions and remote monitoring of patients has shown benefits comparable to those of new chemotherapeutic treatments that can cost upward of £100,000. In one study, they actually had to stop the study in the middle because after the provisional review showed the benefits, it was deemed unethical to continue the study without offering the intervention to the control group. Similar benefits have been shown in other diseases. A lot of them, one of the most common and thus costly chronic diseases, such as hypertension, advanced cancer, diabetes type 1 and 2, heart failure, and the most common psychiatric diseases, such as anxiety and depression. To conclude, implementation of Wellpress and WORCESTER results in better informed and empowered patients and healthcare professionals, which in turn enables better health outcomes and lower costs of healthcare. And in future, this solution could easily be modified to cover any sorts of outpatient disease management, bringing the same benefits there. Okay.
Thank you very much for that.
Thank you.
Sorry, did you?
Thank you.
Okay, thank you. So what we're going to do, we're going to move straight on to Kumar to do Mindwave, and then we'll do questions and answers around PHRs at the end of that presentation. So thank you very much, Zan and Matea. That was fantastic. And Kumar, would you like to start your presentation? We're just handing over it now.
Okay, I'm just about to share my screen.
Yeah.
I should be okay. Thank you so much, Jenny. So I'm from Mindwave. We are a group of designers and developers who develop very much for healthcare and healthcare research. We are based both here in UK and in India, and we really focus on user-centric design. We like to talk to users and understand as to where they are coming from and what their needs are. To introduce myself, my background in terms of technology is computer games. I have been in games for about 25 years, PlayStation 2 and all that, but also NHS. I have been a non-exec director and chair of MAUDSLEY charity, and in fact created and started Mindwave when I left the MAUDSLEY, and we are currently a spin-out of the Biomedical Research Center. But moving on to PHR, John and colleagues from PERSEC have covered much of the background. The way we like to look at is what are the drivers of personal health records. And the four on the screen, one primary is around staying well. And that applies to everyone, not just patients. It's patients, service users, clinicians, everyone needs to stay well. Connecting people, connecting care groups with carers, connecting to patients, connecting around the organization, everything. We need those connections to happen. Informing, particularly patients need information, and they need the information at the right time when they need it. PHRs can allow that to happen. The type of information that one needs when you are diagnosed can be different from when you start a treatment. So you need a record where those time differences can be taken account of. Ultimately, when you have a digital system, it will become rich in data, and therefore you get a chance to have a data-driven system. I would still go back to the users. And who are they? When we started this program, we thought the users would be service users, stroke patients, clinicians, and researchers. And of course, realize that carers are also a very big part of the user groups. And what you see on the slide are the main purpose or objectives for each of these service groups. We have now spoken to well over 600 people, covering all the user groups, And as we go forward, we keep revising and refining these objectives. Running through to the PHR itself, we are currently working with 5 NHS trusts and SCP region. And I'll just quickly run through as to how these are being implemented and what functionalities they have, just to give you a background. As I mentioned, my background has been in mental health. Therefore, there is a mental health bias. We are not exclusively mental health, but that's how it is at present. The project started in South London at South London and MAUDSLEY NHS Trust. And the 3 main things that we did there was integration with the care notes. So the system pulls out care plans out of the electronic patient records. And there are features such as goals and coping strategies, sleep and problem trackers, and a diary function. We then implemented in Oxley's, which is based around Kent. And here it is based on one particular patient group, ADHD. And here the biggest functionality is connecting the various carer groups, parents and teachers. So everybody is able to communicate with each other, see what each other is doing, and be able to take care of the patient. Around 60 to 80 families are currently using this system. In the Northwest, we are working with MERSEY Care, as Jenny mentioned earlier. And here it is now being tested with patients. We currently pull in data, i.e. care plan, from both EMIS in the community and Rio. We are also able to bring in appointments from Rio. And the newest feature that we implemented in MERSEY Care is around a circle. Circle being a way in which the patient can invite carers. They don't have to be the professional carers. It would be people that they are going to a voluntary group with or friends and family, and share with them the data that is within their personal health record. We are now starting work in Birmingham and hope to be in another trust within the next 3 months. Of course, we also need to, before that, we are also with Worcester. And in Worcester, we are actually doing breast cancer care. And this will incorporate the holistic needs assessment and the full pathway through from diagnosis through to treatment. And John earlier mentioned about standards. We comply with all the NHS standards, and we are also be complementary to the NHS app. There have been changes announced recently about how the NHS app will go. We will take account of that, and we will be quite complementary to that. A quick word about NHS Login. So we demonstrated the NHS Login at the Share to Care event a few months ago. And we are also able to get into the system through usual registration and login as well. But this particular diagram shows as to how we are approaching this within the Northwest region, where you could come in through NHS Login, go through to the PHR portal, but also be able to access documents through the e-exchange system. We actually plan to demonstrate that on the 4th of July. Very quickly around the technology and development base, the software is open source, therefore it is available to all of NHS, and the trusts can take it and use it as they wish. And we, in line with our user-centered design, of course, work with the trust to ensure that it meets all the local needs, in many ways meeting the same points that John made in his presentation. Of course, same way, interoperability is important. We are working on fire standards. So the next implementation in Worcester next month will be on the all fire standards and interoperability in that way. We are also working with Farenden, another Slovenian company, on open data structures. Therefore, the PHR will be able to be connected up with other systems that a trust or local NHS system has. So currently, we are continuing to engage in keeping with our philosophy, that is with everyone, patients, clinicians, carers, and managers, to ensure that we are continuing to get a clearer and better picture of what people want. And therefore, I continuously am doing demos of these systems to people. Thank you so very much.
Thank you very much for that, Kumar. That was fantastic. So we actually have one question from the floor that's going to be to both of you. So Kumar, while you're on here, I'll start with you. And Dr. Paul Upton has said, where is the data held? And this is for both suppliers, but we'll start with Kumar. Are they cloud? Are they using SNOMED and Fire, please? So Kumar, do you want to answer that first from Mindwave?
Yes. The choice is made by the individual NHS trust. They are largely in the cloud because most of the trusts we are working with are using cloud, most cases Azure. In the Northwest, it is in AIMS, which many of you will know. In one trust, they use their own servers. In terms of Fire, absolutely, and SNOMED.
Okay, and the same question to Zana Matea.
Okay, so in Wellpress, all data residing in, let's say, in terms of documents, in LPress backbone, which is in AIMS, so for the Northwest as well. But apart from other things, so software solution is cloud-based on AWS and also supporting. We are IHE compliant, based on HL7, Fire, and yeah.
Okay, thank you very much for that. It was good to hear in the talk, and particularly Kumar, I know you mentioned user-centered design, and I know Parsec have been doing a lot of patient engagement around theirs as well. But I wondered, again, a question back to both of you about how the patients are currently finding the experience, or if you're where you are live, how are they finding the experience or feedback that you've had. So again, Kumar, I'll start with you on that one.
Yes, so in terms of the largest number are in Oxleys, and it is the main thing is the parents and teachers, so the carers who are finding the greatest benefit. The way the team there uses means that any questions or communications from them are very quickly answered by the care team. I believe within 24 hours, the care team replies to things. Also, as teachers fill in their required forms, they are available for the care team and also immediately seen by the parents. So that is really being seen as a benefit. Elsewhere, we are mostly on trial in both SLAM, South London and MAUDSLEY, and MERSEY Care. So we haven't got enough data to be able to say what the particular benefits they are finding at the moment.
Okay, and to Zana Matea again, the same question about how patients are currently finding the system.
Okay, so we are also following the same approaches as also Jacob mentioned before. So we are also user-centric because here we have two different solutions. So on one side, we have patient portal, which is patient-facing application. And we also had a user engagement workshop before we actually started with the implementation and everything. And the first feedbacks we got from the patients. And so we were having a workshop with the patients of, or let's say breast cancer patients, and they were saying that they are amazed about the solution. They were see it like very useful for them. But I think that for the next cancer recovery programs will be even much better, because like in colorectal and prostate there are much more events in terms of measurement, appointments, and everything. It's much more complex. And sorry, what was the second part of the question?
It was just about if you were live, how the patients find the experience.
Yeah.
I know you're saying you've got it through the engagement workshops that you've done.
Yeah. Yeah, about the live, we will be live in July, so we're not live yet. We are currently in the middle of development, but yeah, we will shortly be there.
Okay. And this was the only other question oh, hang on, we've got some other questions coming through. So we've got a question from Bilal Vida about how you deal with security. So Zan, while you're currently up, could you answer that question from Parsec's point of view?
Yes, so we are following all major security standards. Also there is also possibility to add additional layers of security, but otherwise it's a web-based application. So we don't share, or let's say we don't have any kind of situation. Anytime when you log into the software or portal, all the data are always retrieved from the backend systems.
Okay, and same question to you, Kumar?
Almost the same answer as Zan. We work with the NHS Trust. The data sits behind the individual NHS Trust firewalls and so on, and we follow all the currently required standards in terms of security and encryption, and we'll continue to do so.
And we have another question that's come in. That question, I think this is specifically for you, Kumar, actually, which says, what sort of implementation lead time have trusts experience on starting with Mindwave, please?
Thank you. Very much depends on the level of changes they want, but I suppose between 3 to 6 months.
Okay. And here's a question for both of you, and this is more about you as, I think, as companies really working in this space. Again, this is from Bilavinda saying, also as a small startup, how do you deal with funding, or how well does it work? They are midway developing but don't want additional investors. So I'll start with you, Zan, if you want to go with that one.
Mm-hmm. Yeah, sure. I would just like to say we as a company are not like a startup. We are spread across Europe. So the headquarters are in Vienna, then our research and development center in Ljubljana, and representative offices in France and London. So yeah, in depends of funding, we also have a lot of different success cases across Europe, and this actually enabled us that we can grow and that we can spread and expand further.
Okay, and same question to you, Kumar.
We, although officially a spin out of a BRC, were unfortunately not funded by the BRC, as is often the case. I'm purely self-funded. Company is a small SME in UK terms, and we haven't taken any investment in. So we are purely dependent on contracts. And linking with the previous question, sadly, much of my time is taken up with the procurement process. That's what takes most of the time. And once we have procured, we can go in 3 to 6 months. But we totally rely on project cash flow.
Okay. We have one more question again from Dr. Paul Upton, who said, have you both engaged with the NICE assessment standards for digital health? And if so, which tier do you fit into? So Kumar, while you're on at this point, do you want to answer that one?
No, we haven't gone to that as yet.
Okay.
We are currently working with NHS Digital and going to be part of the innovation technology payment system. And we will be going through all of the standards as part of that whole thing, engagement with NHS Digital. Okay,
and Zan, same question to you.
Yes, so part of the standards, we have checked most of the standards for the PHR, and according to the standards, we are compliant to the standards. But I'm not sure about this particular one, because I know that there is a lot of different standards in NHS.
Yes, there certainly is. Okay. Oh, there's another question that's come in, again from Bila. Do we have to be established in order to get funding from anyone? I mean, from our point of view, I don't know that question from the Innovation Agency point of view. I mean, Zan and Kumar, do you have any views on that?
Assuming that Bilal is asking the question from the point of view of an SME,
yes.
Most funding agencies would expect it to be some sort of establishment. So at least a limited company or something, because unless you're established in some way, even if it's a small company, it's very difficult to demonstrate good governance and all of that sort of stuff. So it would be useful.
Okay, we're just checking if there's any more questions come through. I think we've covered them. So we have actually covered all the questions that have come through. Thank you very much to Kumar, Zan, Matea, and John for your presentations. They were fantastic, and we're really pleased. Thank you very much. And thank you to everybody who took the time to come on the call today. We hope you found this interesting, and hopefully see you at the next innovation conversation. So thank you all very much, and we'll close the call there.